I'm chairing this session today. I'm a member of the Sigma Conference Planning Committee, former president of the Irish chapter, and a member of the International Board of Directors. I'm really honoured and delighted to introduce Maggie Langins, the European Chief Nursing Officer at the World Health Organization. Maggie is the new Nursing and Midwifery Policy Advisor to the WHO Regional Office for Europe in Copenhagen, Denmark. She is Latvian-born, Canadian-trained nurse, has a bachelor's degree from McGill University and her nursing degree from the University of Toronto. She has completed a Master's of Public Health from the École, and excuse me now with my French here, École des Hautes Études en Santé Publique in Paris. She is a Queen's Nursing Institute Fellow. Over the course of her nursing career, Maggie has worked in various settings in Canada, working in rural health, delivering services to the homeless, and working several years as a pediatric nurse. She is a former fellow at the International Foundation for Integrated Care in Oxford and has more than 15 years of international experience. Her work at the WHO Regional Office for Europe has involved working at the crossroads between health and care workforce issues, long-term care service models, and primary healthcare. Maggie believes that nurses and midwives are integral to advancing progress towards universal health coverage. Her three-pronged approach to working with member states of the WHO European region is to demonstrate that strengthening and supporting midwives can transform, shape, and shift health systems and services to better respond to patients and communities, but also serve as a means for improving gender and racial equality as well as economic resilience. In December 2021, under her leadership, her team launched the roadmap for implementing the global strategic directions for strengthening nursing and midwifery in the WHO European region. During her career, Maggie has worked in more than 20 countries across the WHO European region. Since the onset of the COVID-19 pandemic, she has been involved in rolling out guidance and support to countries to improve mental health and psychosocial support for the health and care workforce, strengthening long-term care services, and maintaining essential health services throughout the pandemic. It is a huge honor for me to welcome Maggie Langins.
Good afternoon, and thank you, Liz, for that introduction. I am so happy to be here. This is my first international in-person appearance. I was actually at the Swiss Nursing Congress, but that wasn't quite international enough. And so I'm very honored to be asked by Sigma Europe to be a speaker here at this event. Yeah, so I have three messages, and Lizzie's already told them, so I can almost go home. But basically, investing in nurses is going to lead to better care. It's going to lead to better societies that are gender equal and racially equal, and it's going to be key to our economic recovery after this pandemic. And as I am in the European region and we are facing head-on the conflict in Ukraine, it's also going to be key to the reconstruction of Ukraine and our region. The failure to recognize this is really, I would say the failure for our systems to recognize this, but also I'm going to challenge us as nurses to recognize this added value that we contribute to our countries with a nursing approach is why we're not getting our nursing research. We talked about that earlier today. We're not getting our nursing research into policy. We're not fundamentally improving health systems and ultimately our healthier societies if we don't recognize this value. So today I'm going to share with you some of the realities in our region. I'm really happy to have just walked through the poster section and seen some nice representation from Croatia, from Italy, from Portugal, not just the stellar research coming out of Ireland, but also all these other countries. I guess I just want to start by saying that my position is a new position. There was a nursing and midwifery policy advisor about 20 years ago, but not positioned in the same way and not with the momentum that we have seen with Nursing Now and all the work that we've done on the State of the World's Nursing Report and Dr. Tedros's appointment at the headquarter level of a chief nurse. And Dr. Hans Kluge followed suit. And when he was elected as the Regional Office for Europe's regional director, he appointed me. And so I have been working since August in this position. And it is so, so special for me to be here today, I guess. I've already said it, you've cheered me on, thank you very much. But it's really special to be in person, to be in Ireland, in a country that I consider, I know you are challenged with all sorts of issues, but as we've seen from Rachel Kenna's presentation earlier on, Ireland is a beacon of light for nursing and midwifery to our region. And to be with nurses, it's really nice not to be staring down a Minister of Health who's looking at me a little bit skeptically of what I'm going to offer and what I'm going to say new that is not about raw nursing and midwifery. I think I'm really well posed for this position, positioned for this position, because as I hope you will see, I think it's important for us to articulate our contribution in terms of patient well-being and health outcomes. And that's really the conversation we're having. So as I said, since I've been put in position in August, I want to share that I have spent the last, I guess it's 8-9 months, doing 4 things that are really important. One, the roadmap was mentioned about implementing the strategic directions on nursing midwifery with the European realities. But also one of my greatest achievements and things I'm so proud of is that we have a government chief nursing officer hub for the European region. And I meet with them every 2 months, not every 2 years, but every 2 months. And we talk about the ways that we can get what nurses and midwives are doing at the front line to the highest level of policymaking. They are twinning, they are meeting each other, they're sharing experiences on how to bring these issues to the policy level. I have a small little team. I have a research scientist, a PhD nurse that deserves her place to guide our policies with evidence. And I have a team member who's really focused on networking and connecting us with all the networks that nurses and midwives are so good at creating. But now it's time to mobilize those networks and use those networks and engage them with my colleagues at WHO and in ministries that are talking about other things like patient safety, primary health care, long-term care. And most recently, I've started to work in countries and really get my hands dirty talking to these ministers and talking to the nurses at the front line and the young nurses. I was really happy to hear a question earlier on about how are we engaging the young nurses and midwives, and that's a huge priority. It's the year of the youth. And we have some activity in Albania later on this year where we're going to be talking about nursing and midwifery professional careers with Dr. Hans Kluge's leadership. So those are some of my, the things I want to emphasize as achievements to date, but there's a long road ahead. And to complicate matters, our regional office serves 53 member states. So this is not just the EU, but it's, sadly I have to say this, it's also the UK. I would have liked to say UK was part of the EU, but yes, so UK, EU, and the ex-Soviet Union. So our borders go as far east as China, including Kazakhstan, Kyrgyzstan, Tajikistan, but also we are inclusive of Israel as one of our member states. So this means 17 time zones, but and for official languages, but actually it also means a very, very diverse scope of nursing and midwifery. The issues that we're facing in our region can be told by the stories of these individuals. We have Georgi in the top right. He has schizophrenia, and in the previous institutionalized system, he's been limited to getting care in an institution, and now he's out in the community, and now he wants to integrate into the community. And it's really important that the country of Bulgaria works with its psychiatric services to reach people like Georgi, to rehabilitate them and to have a meaningful life. We have Maria on the far left, who is a grandmother, and she has diabetes, and she is taking care of her little boy, her grandson, because her daughter in Romania has moved to Italy to get a better job. And so she is handling the double burden of caring for a child, but also being an aging woman with diabetes and a lot of complicated care needs. The bottom right, we have Andrei from Azerbaijan, who has an attention deficiency disorder and is hoping to have a valuable life as he grows up, but is having school issues. And so the issues that he faces need to be addressed, not just in a healthcare system, not just in a very specialized pediatric center, but also with the school and with the municipality. And then we have Olive, who's from the UK, and her husband has dementia, and she, as you see, is older herself and trying to manage an individual with dementia, and having falls herself in the house. And so she's dealing with that complicated care and wants to be able to care for her husband at home, where this is most dignified, but needs some resources and needs some support for herself. So I just wanted to sort of bring us back to what we're talking about. We're talking about patients and their needs, their complex needs, and their wish to live a quality life. And I don't think I have to tell you that you understand, and I hope all of you have some way of relating to these stories, either firsthand or us professionals, that these are some of the things that you as nurses are seeing in your practice. But the reality is that the gap in quality of care, and this number always shocks me, contributes to an estimated 5.7 and 8.4 million deaths annually, and that is more than all the deaths globally caused by HIV, TB, and malaria combined. So it's all those issues around integrating care, ensuring the care is followed through, and that the right resources are being activated when needed. We clearly need to transform our services in the European region, not to mention the rest of the world. Dr. Tedros set out the triple billion targets before his initial election. He's now just been recently elected for his second term. And he says that our vision remains the same as it was when we were founded, the highest attainable standard of health for all people, but the world has changed. And this is why we have articulated a new mission to reflect what our world needs us to do now, to promote health, to keep the world safe, and serve the vulnerable. And this is, as someone said earlier, not to be retweeted, but I think we've got this as nurses and midwives. I think we've had this all the time. And so it's now, I think, our moment. And I hope you're not tired of hearing it, but I really do feel, and I say that genuinely, it is our moment to really shine and to bring this forward. In the European region, we've translated these triple billion goals that Dr. Tedros set out, much with the same headings, but basically that citizens can expect to access care wherever they are, whenever they are, wherever, whenever, however they need. That citizens are to be protected, not just during COVID and similar pandemics that we expect to arise in the future, but also in the security crises like we have with the Ukraine crisis, And also, as we see from the environmental disaster or challenges that we're facing. And then, of course, citizens need to expect to live in healthy communities. And here, this is such an interesting area for nurses and midwives to contribute, because it really is talking about outside of the health sector, really talking about how we engage with the housing sector and the environmental sector. We have 4 flagship initiatives in this European Program of Work 2013 is what it's called, or 13, sorry. The Mental Health Coalition has a huge importance in our region now, really changing the attitudes and systems towards taking care of people with mental health issues. The empowerment through digital health in ways that empowers people, including the health professionals, and does not burden them, but transforms them and transforms the health systems. But also the European Immunization Agenda 2030, which has been really challenged during the COVID pandemic with a lot of questioning, but also before that. And currently we're dealing with several concerns about basic immunizations that we've all grown up very healthy because of, and now new generations of people are quite outspoken about challenging this. And it's really important to renew this agenda. And then, of course, healthier behaviors, incorporating behavioral and cultural insights. And this is where some of my favorite people in the research world, the anthropologists, come in and really talk about some of those nuances that we have to consider when we're delivering health services. I think I've made it clear. I think nurses are really in the driver's seat. I don't want to say that we're alone. I think it's very important to understand how we interact with other health professionals, but we have a real opportunity here. I want to say that we are connectors. I think this is one of the things that we need to capitalize on. We connect with different professionals, but we also connect with different sectors. We connect with long-term care. We connect with housing and homeless commissions that are working to keep people safe. We connect with refugee camps and are working alongside human rights commissions and ensuring and immigration sectors that are trying to secure health for the most vulnerable. We also have a caring lens, and I really like the work of Siobhan Nelson, the dean of my University of Toronto faculty, who wrote about the importance of not thinking about creating a new nurse, but owning our professional identity for 300, 400 years as professionals who integrate the health and care lens, that we really consider how people live in their daily lives, in their homes, and that we shouldn't shy away from that personal touch that nurses and midwives can provide. And I mean, it's extremely important that we are medically sound and that we know the science of our practice, but that we also reflect in that science of practice the value of caring and really being alongside patients when they are most vulnerable. But we also expand care, and COVID-19 has seen that. We constantly, over the course of history, have been finding solutions to problems and been in management roles and leadership roles. And I had a really nice conversation with Elizabeth about, let's be clear about some differences as well, but that the two go hand in hand. And that through that, we have been expanding care. And during the COVID-19 pandemic, we saw that. We see that in rural areas where nurses are becoming nurse practitioners or providing services when there aren't other health professionals. During the COVID-19 pandemic, this study on maintaining essential health services showed that we contributed a lot to overcoming disruptions to mental health, to essential health services. So a lot of nurses became involved in triaging in areas that they hadn't been involved in before, or creating telemedicine. And we heard about the virtual wards that were tested during the pandemic here in Ireland. I don't like the word task shifting. This is from one of our publications, but I'm on this rampage within house to say it's called task optimization. I think shifting is too rigid and may lead to some people feeling like something's being taken away from them. Whereas what we really need to talk about is task optimization. So whoever is that most appropriate person, and honestly, in some cases, it can be a physiotherapist or a social worker who's better positioned. But we as nurses have that lens of advocating for the patient and finding those moments where, hey, this patient needs that social worker to be a lot more involved because that's who they trust. And then, yeah, so these are some of the areas that we saw countries overcome disruptions in essential health services. And overwhelmingly, there were nurses behind these stories. So we need to understand, you know, what were the enabling work environments that were created for them to do this, but also to maintain them and sustain this moving forward and not lose this experience and knowledge. But because of several issues across our European region, we're losing nurses. And, you know, as excited as I am to have this position, someone said to me coming in here, gosh, your job must be really hard right now. and as Rachel was saying also earlier, you can't really be prepared for the position until you arrive. But this is not an easy time. We already were losing 20% of nurses to an aging workforce before this pandemic, and we are estimating that that is going to be much higher as we emerge from this pandemic. And I think that this is because we aren't addressing those systemic issues that we need to address nursing recruitment and retention. One of the things is gender and racial inequalities. And I'm going to start with this and I'm going to end with this, because this is actually one of the highest growing sectors, the health sector. And yet the workforce that is 70% women and the nursing workforce that's 90% women only holds 25% senior roles. So they're not actually getting into those positions to help with decision making. And women, and we see this in nursing, are clustered into lower status and lower paid health and care roles. And we need to value that health and care. It's not straightforward. It's extremely complex. So our researchers need to convey that. We need to position it in terms of long-term care and what we need to strengthen access to care for older people. But we need to articulate what it is we do as nurses and midwives. And I was really happy to see in Rachel's presentation that pay gaps are going to be looked at. And I think we cannot ignore the gender pay gaps that we see in health and care. And I'm very proud to say that WHO has been working with the International Labour Organization and will be issuing at one of the UN General Assembly special sessions on sustainable development goals, so outside of WHO, the first pay gap report in the health sector. And there are going to be a lot of messages there for nursing and midwifery. You get what you pay for, I say to ministers. I mean, if you want this workforce to thrive and you understand it to have this contribution, you have to pay for it. And the other thing that, and I sort of have goosebumps thinking about all the workplace violence that is happening. It happened during COVID, but I was on the phone with the director of nursing development in the Ukraine and how this plays out during war. It's really, really sad and shocking that we tolerate this. And that's, again, tolerated in this sick, toxic gender dynamic that we have. So I think this is a really important place to address it. And But if we don't, we continue to see underinvestment in this sector. And nursing here, please read sort of nursing and undervaluation of nursing, the shortages of nursing, and poor working conditions. So a little bit about our region, in the European region. We ranked during the State of the World's Nursing report quite high in terms of the ratio of nursing personnel, density of nurses to patients. But they are not where we need them. They are not in the services that we need, and they're not geographically distributed. They're also not empowered when they are on the fringes of healthcare to be considered as nurses. They're sort of, or that lens is not recognized. So, and we're also missing here in this data a protected scope of practice for nurses. So a lot of countries reported nurses as nurses, but actually they're perhaps more of the profile of an assistant or a community health worker, and that's because they are not at all meeting the standard of nursing quality education anywhere in their country. We also see that only 56% of European countries reported having nursing leadership programs. This was surprising. This was sort of in the lower end of the regions in WHO. So we're often sort of promoted as a region with more security, job security, more opportunity, but actually we're not enabling them with leadership opportunities. And this is, again, going back to that question of how do you create a pipeline for Rachel to have nursing leaders if they are not getting leadership training and understanding the mechanics of this and understanding health systems. So this is very worrisome, especially because we see that government chief nursing officers and nursing leadership programs are associated with stronger regulatory systems. So this is what we have to tell our policymakers, that it's education regulations that will be strengthened with the chief nursing officer role, but also the leadership roles that the leadership training that understands why I'm learning about health systems and my input to improving systems. So building nursing capacity in the WHO European region is, as you know, and as has been mentioned, guided by the strategic directions on nursing and midwifery, which was accompanied by a resolution. And so we've had several resolutions on nursing and midwifery over the last 70 years, actually, but none have been accompanied by a strategic direction that says, this is what you have to do. And we were able to do that this year or last year because the global strategic directions on nursing midwifery were equipped with the State of the World's Nursing report that was the largest body of evidence that the WHO had collected about nursing impact. We also have in this resolution the important statement that we encourage nurses to be in leadership positions at all levels of decision making. And we want to see more government chief nursing officers. So that's why I got down to business as soon as I was appointed to rally a group of chief nursing officers. And as I said earlier, they are not always supported with the financial resources, the support staff, the mandate, the avenue to the ear of the Minister of Health, as they are here in Ireland, but they are on a journey towards that. And that's what we do in the hub to strengthen them and to help them understand how they can do that. And then, yes, there's the roadmap, which is really mobilizing my network and our network, because I don't do this alone, in terms of how we're going to implement these strategic directions on nursing midwifery in our region. Some things I guess I want to emphasize here: the health labor market framework. This is key to the document and also to all of our health workforce strategies at the WHO. And it essentially is just trying to convey that we cannot approach one thing without the other. So you cannot approach, the jobs without having the mechanisms of education to support those jobs, and you cannot do it in isolation of finance minister and reflecting on what this is going to cost, but also how this relates to the existing workforce and how you bridge this with the existing workforce in a way that ensures retention and recruitment. So you'll hear the WHO talking a lot about the labor market framework, because surprisingly, when it comes to health systems, and without a chief nursing officer in place, you don't have someone, putting these things all together. And so things are, especially in the poorer countries in our region, approached by development organizations of just, a CPD course or just an education reform, and nothing is linked up to the regulations, the financing mechanisms that we need to make this sustainable. So in terms of jobs, this is the strategic direction to really increase the availability of health workers by sustainably creating nursing jobs and effectively recruiting and retaining midwives and nurses in an ethical manner. And this is becoming very important. There are several member states that I am seeing in our region quietly trying to absorb the refugees from Ukraine without a plan to support the reconstruction of Ukraine. And we know that amongst these refugees are nurses, because they are predominantly women, but also post-pandemic. And there is a global ethical code of practice for recruitment that says that you cannot recruit from countries that have a shortage. And the reality is that actually we have a shortage everywhere. Also, planning and forecasting is a priority. In our region, I cannot tell you how surprising it is how many countries don't actually know how many nurses they have. And if they know, they don't know the gender. They don't know if they're working full-time employment. They don't know where they're working. And this is all intelligence that's really important for planning and forecasting. So this is one of the areas that we're working on with Tajikistan, a beautiful country on the border of China and Afghanistan, and with a Persian heritage. And yeah, we're working with them and our network to strengthen their understanding of how to build a registry that's also then linked to CPD, and understand and get all the information that they need to plan this nursing workforce in a meaningful way. We're also looking at, ensuring adequate demand and making sure that they're linked to their priority areas. So not to go in just as we're strengthening nursing, but we have an ask to strengthen nursing and primary health care. So let's link up the demand and make it a demand-driven system of planning and forecasting, and not just producing nurses and midwives and not thinking about that. So that's also something for the education sector to be really aware of, that when it's recruiting and young nursing students, that it sees itself as aligned with health policies. And then, of course, there's the policy priority of attracting, recruiting, and retaining. And this means engaging a lot more with our young students. And I'm happy to say that the European Nursing Student Association will be having a seat at the table at WHO as a non-state actor, separate from, the European Nurses Forum, because they deserve a voice. And I encourage everyone who knows of a nursing student association in this region to please connect with me, because we're trying to make that group stronger. In terms of education, again, it's about aligning it to the roles and the health priorities, but also to optimize the domestic production, to really target your domestic population, your local population from nurses and midwives, and also to design education programs to be competency-based and really apply effective learning designs. So one of the things that, and I'd be curious how it happens in some of the more Western European countries, but in the Eastern European countries, we see that often it's physicians teaching nurses, and or there are nurses that have no practical experience. And I was also interested in seeing a poster out there that was talking about the sort of retention strategies of nursing students, and it identified as one of the findings that nurses in study stage really like to engage with people who are practicing, and not just people who are removed from practice, so that they're all the more prepared, but also that they have time to practice. And this is extremely challenging in community long-term care and primary health care, because the nurses there have not been planned for appropriately. They're overrun. They sometimes don't have or haven't been considered in leadership and mentorship skills, and can't absorb the students that are trying to learn in those areas. So they inevitably go to big hospital centers and get their skills and training in big hospitals. And this is not what we want. So we really need to think about those pedagogical models and methods, but also how technologies can help. And again, I saw a great poster about simulation training through remote learning, and we need to look at that and position that as an opportunity. Maybe not the whole thing can happen on a virtual platform, but we must consider all options. In terms of service delivery, this goes back to actually, Rachel made a comment today that one of the places in her, one of the groups that she engages with are the regulators, and that she works with the Professional Regulation Committee, I think it was. And this is so important, that regulation is enabling flexibility, that we are sort of that we manage risk as it comes, rather than we try to eliminate risk from the get-go. And then what I face when I go to countries is sometimes the resistance is within the nursing workforce. I don't want to do that. Do you know, I'm not going to get protected if that happens, if I start working. So really, and again, the virtual ward example was excellent in that it talked, and that Rachel addressed the risks of working alone in the community by having transport accompany these nurses, have a second nurse on hand, having a GP at hand. So these are some of the workplace considerations that I think are really important, that we know are very important and need to be a policy priority as we think about new scopes of practice. And then I've already said and I shared how important I think the leadership piece is. And there it's really just responding to that gap in leadership skills development, and making sure that our senior leaders are enabled. And by this, I mean that also leaders are not only at the policy-making table, but they're also in the clinical setting, and that linkage is made, that I'm a leader in this clinical setting to improve services for patients. We are reinforced in our mandate to invest in strong, resilient, and inclusive health systems, and to take action on all levels of societies to heal the divisions exacerbated by the pandemic with the Monti Commission. And this was a special commission that was created sort of 5 months into the pandemic under Italian leadership. Ex-President Monti, for those of you who are Italian, and really looked at the ways in which we want to rebuild our societies. And I think that at least two of the sort of objectives and recommendations of this commission resonate really well for us, and further support our work as nurses and midwives. I then want to bring your attention, because I'm so passionate about the gender equality, that we have a gender health workforce initiative at WHO led by my colleague, Dr. Michelle McIsaac, who also helped steer the work with the ILO on the pay gap. But there's some really interesting reports there that I think resonate for nurses and midwives in terms of addressing occupational segregation, improving decent work and improving leadership and governance. So this is sort of just a placeholder to share that you should look those resources up to support your nursing and midwifery education training. So in addition to really, and this is my last-ish slide, that in addition to the global strategic directions of nursing and midwifery, I urge us all to, I'll say, continue, because we are in this business. Each and every one of nurses who have considered nursing as a viable profession can understand that our transformation will really rely on us taking an approach that that builds our health systems on the foundations of equality, our employment practices that they are based on equality, that we address the social norms and stereotypes, and rather than changing women and nurses to address to work within health systems, to have health systems and systems adjust to what we have to offer. But also that our workplace systems and cultures are supportive of us and of each and every one of us, and that we really enable women and women of color to achieve in this workplace. And it's in that way that I really think, that we're going to achieve my dream of showing the ministers of health that I meet that investing in nursing really means better care, gender parity and diversity, and resilience and recovery. Thank you.
I just want to thank you, Maggie, for another incredible keynote presentation. And one thing that I heard, I think that's been kind of synergistic across all of the presentations, is this need to articulate and recognize our value as nurses. And I think having people like yourself and Rachel positioned at such, senior leadership level influence in policy is absolutely fantastic. So thank you very much. We have time, plenty of time for questions.
Any?
Thanks so much for that. I just want to dance around and probably cry a bit and hug you and say thank you for me feeling that I've been right all along. I don't like being wrong. So my name's Joanne. I'm the Chief Executive at the Foundation of Nursing Studies. It's a UK charity, and we focus on person-centeredness, person-centered workplace cultures, person-centered care, person-centeredness amongst ourselves as citizens. And we're part of a global community of practice. It's enormous. Nobody knows about us. I would like to offer to join one of your networks.
Yeah. Because
I would imagine it's probably CNO level, CMO level in government.
Mm-hmm.
But when we struggle to have a voice, but actually we're on the ground, we're getting on with it. So the well-being, the mental health, psychological support right the way through COVID, we've been doing it the whole time online. And we've got some amazing results, some fantastic results that I'd like to share with you. But as a public health nurse, of which I am and have always been, I feel that we are in Europe, we need to get a grip on this postgraduate, because I am a specialist community public health nurse. But when I revalidate, thank you. I'm a health visitor in the UK, that's kind of what it means. But when I revalidate in November this year, I'm already thinking, should I not tick that box anymore? Because I'm not practicing as a family public health nurse. And I struggle with that. I struggle with my identity, because that's my identity. I use it every day. I've used it all week that I've been here. And then it got me thinking about postgraduate CPD and postgraduate programs. And when we look at all the public health modular programs that we can all join, we can all go and do it. It's not nursing. It's not nursing in public health. It's not the wider public health that we need. And so I don't know whether you're thinking about that within the WHO. We've got brilliant frameworks, the knowledge and skills, public health knowledge and skills framework. We've mapped it to our future nurse standards in the UK. So we know where we are with that or not. So we've done a lot of mapping, but I don't know whether you know about it, because we don't have a chief public health. Well, we have Viv Bennett, but she retires in August, and her focus has been on health visiting and school nursing. And I want the next person coming into that job to have everything that you're talking about today, but I don't know whether they will. So I think there's a lot of ends that we need to start tying up. And there's a lot of charities that would really help you to do that, because we're free to speak. We're free to be independent. So, you know, it's a conversation which is amazing. Thank you. Really, thank you.
Yeah, thank you so much. You touch on a few points. Indeed, that's why you've made your points. But it makes me think of how much more important it is to understand that labor market approach in terms of public health nurses. They're often sort of not recognized for doing nursing anymore because they're sitting somewhere else, or they've gotten CPD, but it's not considered nursing CPD. And equally, as you point out, that something that's specific to public health nursing is lacking. So there's no sort of leadership and governance in that area. So we're definitely, we have, and I worked on this a while ago, and they just launched it a few months ago. It's a framework for public health professionals that I can share with you. How far they're going to get, I mean, it's sort of more broadly public health and trying to understand the dynamics of public health practitioners and how they cross boundaries and how to recognize that boundary crossing. So definitely, I love, I mean, I spend a lot of time just talking on webinars and reaching out to people to learn about what they're doing. So, and we now have the GCNMO Hub as a forum where people can learn about it, but also there's a lot of country work. And actually what's interesting is in the Eastern countries, there's a long tradition of a public health nurse. And with the sort of called the patronage nurse for, I think, some of, and Croatia is very familiar with the public health nurse. But in some countries, it's been sort of washed away as part of the sort of previous regime, or they're not seeing enough investment. So it's there that your sort of network would be really important, because some of them are really wishing to strengthen it, and for others, we're saying you should strengthen it and reinvest in it. But yeah, it's interesting that you make the comment, because it's coming from the UK context. So while so much is different across our region, there's some very common themes there. So thank you.
Thank you.
Thank you so much for a very, very impressive presentation and insightful. My name is Thora Hafstensdóttir. I'm from the Netherlands, and I have a question. I am just wondering, I've been looking into the education of nurses for many years across Europe, and I am always worried about the countries that do not have bachelor education.
Mm-hmm.
How do you see that? It is a huge number of countries still in Europe that do not have bachelor education. And how do you support these countries, especially in the eastern part, I think? We are talking about, we are sitting here in Ireland, and I'm coming from the Netherlands, and we have great systems here, although they are having difficulties and will be more difficult. But I am worried about the situation in the eastern countries, which will have impact on all things in Europe.
Yeah.
How do you support them? How do you look at the educational levels?
It's one of the biggest asks, I'll say. So there's a few things around it. One is that we, in the global strategic directions on nursing midwifery and the roadmap, have said unequivocally that we need to move towards bachelor's education training. So this is the business that we are in to support you as countries, and that this is linked to improved quality of care. But I think what is also equally important is that we recognize the vocational training that is happening in these countries, and that it also One, it is strengthened to include the foundations of research and sort of evidence-based practice, and placements in relevant settings, so that we can gain the appetite of the ministers to see, wow, if you do invest in this, we're slowly moving towards bachelor's education, basically, because that's what really distinguishes a bachelor's program, is that attention to research and that attention to evidence-based practice. So because the journey is so long for bachelor's education training, I don't hide from saying that this is probably a 10-year journey for you. But what we can do is we can strengthen your vocational training. We can make bridging programs. So in North Macedonia last week, we had a mission and I was sitting with the Minister of Health, which was so exciting to have a Minister of Health say, I like this idea. Let's strengthen the vocational training. Let's develop a cohort of nurses that are going to get bachelor's training in Slovenia. And because I have the partnership in the GCNMO hub, I was quickly able to find some Slovenians who are culturally and historically similar to North Macedonia somewhat. They were able to accompany us, and they are going to train a cohort of bachelor's trained nurses to start improving the training of vocational training, and then bridging slowly towards bachelor's training. But this is the problem with the migration, of course, right? Because, anyone who goes into nursing and midwifery goes into it because they want to improve the lives of people. And we need to honor that and respect that and give them the dignity of a good education. And when it doesn't happen, they leave. So yeah, I'm working on it from two fronts, is really being clear that bachelor's education is the course of travel, but that we can strengthen what they have towards that.
Thank you.
I'm looking forward to some long-term care, community health questions.
I think that's definitely it. My name is Catherine and I'm from England. I think probably this morning, having spoken, I think you probably highlighted exactly what I'm going to ask about. So in terms of, we know that globally, demographic transition is getting a little bit more than we would like. I know you mentioned about the older person in terms of your planning. What I want to know, because you've mentioned that you've got some PhD nurses in your team, I want to know if you've got some clinical nurses on the ground who are actually provided day-to-day care in the hospital. And if not, do you think that those people could help to push your policy and give you more ideas of how we can do that in the community? The second question is around equality. I know you mentioned about gender equality, but in terms of the mass migration, I would say across all boundaries, what is your view and ethnic minority in terms of representation within your current role?
So going to the first question about making sure that we have clinicians also, I relate to Rachel in that I came into the position with some more clinical than research experience. So that's one thing. The other thing is, I interact with clinical nurses all the time, but it's a good point that having it. One of the challenges, I think, and I face this as a practicing nurse, is that often our systems do not enable us to bridge and work in policy. I see my physician colleagues be, in a policy position and do clinical practice, but then that the nurses had to make a choice if they're going to go to the research center of the hospital or if they're going to work with the association and leave practice. So I think I think you highlight a really important opportunity. It was already something I was thinking about this morning to make sure that, and it's something I wrestle with every day, that I loved my patient experience and how I feel almost increasingly disconnected from it, and how do I stay connected to it? But I do rely on practicing nurses. I always check in with the practicing nurses when I go to countries, but I think there are mechanisms of improvement. And I think the second question is one that I think is sensitive and very, I'm really sorry that I don't have a good answer, that we're addressing the gender equality. We're not always addressing representation of minorities, but Dr. Tedros has done that in various ways to get, you know, our staff to be more representative of the world in which we work. And as a nursing and midwifery program, that's something that we need to address. Just recently, one of our chief nursing officers, actually Sue Tranca from Wales in UK, brought up this point as well with a new Congress in the Netherlands, and that we had this totally white panel of women and men representing a profession that is not the color of this profession. And we're going to have a session on it as a result. We both got in there and said, let's, you know, do this, but it's a slow moving target, Catherine. But I think it's, you have my full support for it. So if you want to come and work at the WHO and help me shape that, no, but it's something that we need to address. And that's also something I don't like retweeting, but I mean, I tweet on those issues, but we do need to address it.
So we'll take one final question.
Great. I'll be very quick. Maggie, it's an honor to have you here with us in Dublin, and thank you very much for your presentation. You're inspirational, and well done on all the work that you're doing. My question is quick. Your strategic directions, have all of the countries embraced them? And if not, is there something that we can do, not at our level as government chief nurses even, but as professionals in each of the individual countries to help, I suppose, spread the word and get people, encourage people to get involved? Is there anything that we can do to help your work?
Yes, you can promote your strategic the roadmap for sure. I think that it is a question of me road tripping with the strategic directions to different countries. Their appetite is greater than ever, but yes, it's more the global strategic directions on nursing midwifery that need promotion. And I do think that every faculty, every training institution for nurses and midwives should be abreast with this, because it's accompanied with so much evidence as well with the State of the World's Nursing Report. It's not perfect evidence, but it's the best we've had forever. And all the research community can support it even more and reach out to us also to strengthen the evidence, to continue and submit for the next State of the World's Nursing Report and State of the Midwifery Report. So definitely, I think each and every one of you, if you could share the strategic directions for nursing midwifery today with one person who you think doesn't know about them, that is in a teaching position or is in a clinical management position, and say, you know, there's some teeth in this. Let me have a conversation with you on what I heard today from Rachel or from Maggie. I think that's amazing. And that's, I think, what nurses and midwives do so well. And even better if you reach outside of sector. Not to a nurse and midwife, but to an engineer. We had an engineer in the room earlier on. There he is, in a different coat. I was looking for the pink jacket, which I really liked. But an engineer, environment, you know, Department of Environment. You articulated so beautifully how nurses and midwives connect with the environment. I'm not there yet in terms of getting my head around all these things, but yeah, That's what I'll say.
Thank you so much, Maggie. And I just want to echo what Rachel said and say you're an absolute inspiration. And we're very
Thank
lucky to
you.
have you in the position you're in. And you've left us with a great call to action that everybody can influence change. So thank you very much. A round of applause.
Sorry, Lizzie, I need to say one more thing. When you say thank you to me, I need to thank every one of you. And that's something I missed at the very beginning, but all of you who participated and cared for people have been caring for people during the COVID pandemic and the most vulnerable. That needs to be said. Thank you.